Just share my screen. Oh, can you see that, Chris? And
Yep, it's in that mode where it's like the small screen.
Right, okay, right, hold on. I need to.
I think it's display settings, is it not?
Right. It's about which screen I choose. Sorry, this always happens. Stop sharing, share. That better?
Yeah, that's normal now.
You got the full, yeah, you can see the full slide. It's flipping it the other way on my screens. Apologies, everyone. It's like not putting the screen. I think the screen is the wrong way around on my end. Okay, so I'm Dr. Mullally. I'm one of the hematology consultants from Whittington Health and UCLH. So I help look after, along with the rest of the team, patients with sickle cell disease and other sort of inherited hemoglobin disorders. So I'd asked to sort of give this talk just to sort of give an overview of the management of pregnancy in sickle cell disease. Okay, so I'm not going to spend too much time over the background of sickle cell disease itself, but I'll just sort of very briefly do a couple of slides and then move on to sort of pregnancy specific things. Just because the audience is obviously a bit, I think, is mixed. So sickle cell is a recessively inherited condition, so it means that you need to inherit one abnormal gene from both of your parents. So if two people are carriers for sickle cell disease, so i.e. AS, so one copy of a normal hemoglobin A gene or adult hemoglobin gene and carry a sickle gene, there's a 25% chance with each conception that couple have that they could have an affected child. I'll go on to talk about the different genetic combinations that can cause a sort of sickle cell, what we call phenotype in real life. Although the most common form is where someone inherits two copies of the sort of abnormal sickle hemoglobin gene. And there's around 15,000 patients sort of registered in the UK with this disorder, which makes it one of the most common inherited disorders in the UK. There's probably actually more patients than that. That's based on sort of older data. And there's a national hemoglobinopathy registry that's trying to sort of improve that, the sort of recording of the number of patients that we actually have. And up to around sort of 300 babies a year are born in the UK with any form of sickle cell disease. In terms of sort of the pathophysiology, so what that genetic defect does is that it means that the red blood cells that obviously normally carry your oxygen can sort of change shape in the right circumstances. So that's normally when there's conditions with conditions of low oxygen levels. So that would be in your sort of veins and capillaries rather than in your arteries, and those red blood cells then change shape in a sort of irreversible way to become sickle shaped in nature. So when you look at these cells down the microscope, they actually look like a sickle, sort of a scythe shaped cell. And the issue is that they don't live very long, so a normal lifespan of a normal red blood cell would be 120 days or 3 months. But because of the abnormal shape of these cells, they break down very easily, and they might only live sort of a number of days. So you have a massive increased turnover of red blood cells, and you essentially break down more of them than you make, and therefore your overall total hemoglobin level drops, even though your bone marrow is trying very hard to make cells, it can't make normal ones. So the patient's always anemic, generally to one degree or another. And because of the breakdown, we call that hemolytic anemia. So that releases things like bilirubin into or unconjugated bilirubin that's not yet passed through the liver into your bloodstream, and that's what often causes patients to look a little bit sort of yellow in the sclera, in the white bit of their eyes, and that often increases when someone has a sickle crisis, because the sort of rate of breakdown of the red blood cells increases. From a sort of clinical point of view, in terms of the patient's experience, that process causes the red blood cells not to be very mobile or deformable to sort of flex and fit through small blood vessels, and they can get stuck and cause sort of like, you know, aggregates of red blood cells stuck together in small blood vessels. And you've got lots of your bones are obviously very vascular, and you have lots of blood vessels in your bones, and if the blood flow can't go through your bones, you basically get ischemia from that. So it's a bit like when someone has angina because they're starving their heart or their heart muscle of oxygen. It's like starving your bones of oxygen, and you get this intense, very deep and unrelenting sickle pain in the bones. But there's a lot more to it than just the acute crises that cause pain. So whether or not someone's having an active sickle crisis or not at any given time, there will still be this ongoing sort of breakdown of red blood cells and hemolysis. And that's actually harmful to your blood vessels across your body, because obviously, wherever you've got you need to supply blood, you've got blood vessels. And that process releases lots of toxins, and it damages the walls of blood vessels, big and small, and causes problems across every organ system which are listed there. And as a result, you can get a variety of acute and chronic complications from sickle cell disease in almost any organ system that you can think of, and then also sometimes flares of an acute on chronic problem. So you can meet people, and the other thing is that often patients look, when they're well, they look complete, look like there isn't anything wrong with them. So you could walk past someone with sickle cell disease or quite severe sickle cell disease in the street and not have any idea that they have this problem. And someone can be well one day and well and very unwell the next, and deteriorate quite quickly. So they're sort of high risk patients, really, from the point of view risk of deterioration. And just because someone looks sort of normal in inverted commas from the outside doesn't mean there's not a lot else going on the inside. And some of these patients are incredibly complex, and it gets more complicated sometimes when pregnancy is put into the equation. So how I think about sickle cell disease in pregnancy, or if I'm sort of talking to a patient about it, try and split it up into thinking, well, how does having sickle cell disease affect being pregnant? So what implications does it have on the on the baby, and what would be the normal expectations of sort of pregnancy for someone and the potential complications? How does pregnancy affect sickle cell disease? So stress in any form is a common trigger for sickle crises, and pregnancy is a stressed, in inverted commas, state, because it's physiological stress on the body to try and essentially grow the fetus. So often some conditions in pregnancy, medical conditions, get better, worse, or stay the same in pregnancy, but in general, pregnancy is a challenge stroke destabilizing event in someone who has sickle cell disease. And then in an ideal world, we would like all pregnancies in patients who have sickle cell disease to be nicely planned and patients optimized before they become pregnant. But that was obviously not always the case, and people will come and see us in clinic at a certain gestation already in pregnancy, and none of these sort of ideal world things have been done, and you have to then catch up. But that's life, really. And then there are certain things we'd expect in terms of antenatal care, intrapartum care. There are specific risks in the postpartum period. So obviously, once the baby's out, the patient is not sort of home and dry from a sort of risk of sickle complications perspective. And obviously, we need to not forget the baby. That's more in terms of effect of sickle on sort of fetal growth, but actually also whether the baby themselves might be at risk of sickle cell disease. So if your mother is SS sickle and has got two abnormal sickle genes, by definition she will donate one of those to the baby, and then what the baby has, i.e. are they a carrier or just more than a carrier, will depend on the father's hemoglobinopathy status. So what guidelines exist to sort of help us? So lots of trusts that sort of see patients regularly with sickle cell disease will have a local guideline or a network guideline. The RCOG and BCSH guidelines are updated in 2021. So there was previously, I think, a 2011 sort of green top guideline from the RCOG. But that was sort of that's been superseded by a joint RCOG BCSH guideline in 2021. There are specific guidelines about transfusion in sickle cell disease, and I'll talk about that later in the talk. And there are also overall sort of overarching UK standards for the care of sickle cell disease in adults, which were last published in 2018, but are still very relevant. So as I said before, there's lots of different genetic combinations that can cause a sickling disease in real life. I've highlighted the two that are probably the most severe, and that's where the most evidence lies, because they're more common than the other genotypes that are not highlighted there. So a lot of the sort of guidance and evidence and study data and information comes from patients with SS sickle or S beta 0 sickles. That S beta 0 is where you've got one sickle gene and one beta thalassemia gene that doesn't work at all. So in both of those conditions, you can't make any normal adult hemoglobin. The one that patients, the other type of sickle that patients will see, sorry, the clinicians will see most commonly is probably SC type sickle. So that's where you have one copy of a sickle gene and one copy of hemoglobin C gene. And that is generally a milder disease. So you tend to have almost a normal hemoglobin in some patients. So it's sometimes quite hard to tell from just looking at the blood count that they might have sickle cell disease. But you can look for other features. They tend to get less in the way of painful crises and less in the way of sort of some of the longer term complications from sickle. That doesn't always hold true. And the text box on the right is sort of a caveat to say, actually, one of the most important things that you do is not assume because if they have in inverted commas milder genotype of sickle that they're going to have an uncomplicated pregnancy or that they don't have severe sickle cell disease, because we meet patients with, for example, SC type sickle, which in the textbook version would be mild, that have lots of crises, lots of chronic complications. So really, you have to take into account both the genotype and what their real life phenotype is, i.e., take a history, look at their previous notes, what complications have they got, how often do they come into hospital, do they come into hospital at all, and obviously if there's a previous antenatal history, so if the patient's been pregnant before, or then that sort of will set the scene of it as to what you might expect in a subsequent pregnancy. But obviously, if it's the first ongoing pregnancy, it's a little bit more difficult to predict. So why do we need specific guidance? There's around, it depends obviously each year, but there's sort of 100 to 200 pregnancies a year in women who have sickle cell disease. Most of those obviously will be in London, but patients will be seen all over the country. So I used to work as a consultant in Nottingham, and I had a much smaller service for sickle cell disease. But we would at any one time always have at least one patient pregnant with sickle cell disease that we would be seeing in the joint obstetric hematology clinic. Whereas in, for example, UCLH, we might have a few at any given time. It's important because there's an increased risk of complications that are specific to sickle cell disease in pregnancy, and there's also an increased risk of complications that could happen to any pregnant woman in pregnancy, and I'll just touch on those briefly. So in terms of specific complications of sickle cell disease, as I've said, it stresses the body, so you're more likely to have a vaso-occlusive crisis. That's where there's sort of ramping up of sickling in the body, and there's blockages of blood supply to bones that causes extreme pain. Now that process can release lots of sort of toxins from the bone marrow, because you're essentially sort of killing off bits of your bone marrow, and there's lots of fat in your bone marrow, and that releases sort of fatty, sort of what we call emboli. So it's almost like a shower of sort of microscopic fat particles into your bloodstream if the sickling is happening on a widespread basis. And that then circulates around your body and lands up in your lungs, because your lungs are a bit of a filter for sort of for your bloodstream. And that can cause an inflammatory reaction in the lungs, which then leads to something called a sickle acute chest syndrome. So this typically occurs sort of 48, 72 hours into a sort of an established sickle crisis, and is characterized by sort of hypoxia on room air. So it's important that you know what the patient's oxygen saturations are when they're well. So if you look at a previous clinic letter, that often tells you, because if they're then lower than normal, that's significant. Obviously, hypoxia in a pregnant lady, there's a wider differential, sort of including pulmonary embolism. But in terms of a sickle chest syndrome, what you see is hypoxia. You see often bilateral chest X-ray changes, so it almost looks like heart failure. So you get these fluffy infiltrates. Often hear crackles on the chest. You may get a fever because it's an inflammatory process. There may also be an element of a community-acquired pneumonia on top, or that can occur sort of at the same time or afterwards. And the treatment of it is supportive measures, so oxygen to maintain saturations above 94%. An incentive spirometer is sort of a device, a bit like it's a bit like blowing on a syringe. An incentive spirometer, it sort of encourages you to push your diaphragm down when you're breathing out as much as possible to ventilate the bases of your lungs. Obviously, the cornerstone is adequate analgesia, because if someone can't take deep breaths and oxygenate themselves properly, then the sort of sickling in the lungs will get worse. But normally, to sort of break the cycle of sickling and inflammation in the lungs, you have to sort of transfuse the patient out of it. And not only does that raise their hemoglobin, it's about diluting or getting the sickle level in their blood down, because they'll almost have 100%. Someone who's SS and not transfused will have 100% sickle cells almost in their blood. And to sort of break the cycle of the inflammatory cascade they're causing, you sort of physically have to sort of either dilute them down with a top up, which is like a normal transfusion, give a few, 2-3 bags depending on the hemoglobin level, or an exchange transfusion, which is where we use an apheresis machine, so a special machine that takes blood out of the patient and puts it back in at the same time, to essentially exchange all of their red cells for normal donor red cells. And that can, depending on where you work, that may or may not be available 24/7. And then less common things that can happen to patients with sickle cell disease sort of acutely. You can have a stroke related to sickle cell disease, although that's less common in adulthood compared to childhood. You can have what we call hepatic or splenic sequestrations. That's where you get sickling in the liver or spleen, and they enlarge massively, sequester blood, so they pull the blood into it, so your hemoglobin level drops massively in your blood. And again, you tend to transfuse the patient out of that. And patients with sickle have got increased risk of osteomyelitis. So if someone with sickle cell disease have got sort of a temperature of unknown origin, or if they've got very focal pain in a bone, not sort of as part of a generalized crisis, and raised inflammatory markers and temperatures without another obvious cause, we sometimes think about whether the infection might be in the bone itself. The things that can happen to any lady in pregnancy that are more common in sickle cell disease, so for example, include pregnancy-induced hypertension. So blood pressure checks, are done regularly in pregnancy anyway, but more regularly in women with sickle cell disease. Preeclampsia is more common. So that partly has to do with sort of abnormal placentation. So you sort of essentially get the effect of sickling in the placenta, which means it sometimes doesn't implant completely normally at a microvascular level, and that it underlies the reasons why there's an increased risk of pregnancy-induced hypertension and preeclampsia in women with sickle cell disease. So they essentially, I'll go on to talk about that, but they essentially all get aspirin as a result of that. There's an increased risk of venous thromboembolism. So obviously pregnancy is a higher risk period of a woman's life for thrombosis because of the normal changes that happen in pregnancy. Your clotting factor levels increase to stop you bleeding at delivery. You have physical obstruction of your veins draining your legs because of the growing fetus. But sickling itself is an additional thrombosis risk factor. I think in a subsequent slide, I do mention the RCOG-VT risk assessment score, which obviously is done at booking, every sort of inpatient interaction, and reviewed at antenatal visits. But it scores, those of you that are sort of midwives or working on obstetrics will know that it scores a 3 automatically, which means that pretty much, all women we recommend with sickle cell disease, we recommend prophylactic low molecular heparin from 28 weeks onwards. And if they then have further risk factors on top, so twin pregnancy or increased BMI, smoker, age over 35, as per the risk assessment, you might be having a discussion about sort of starting it at the time of sort of diagnosis of pregnancy. Infections are sort of more common, so UTIs, which can be a problem anyway in pregnancy, are more common in sickle cell disease, and are more likely to progress to sort of more severe infections like pyelonephritis or sepsis. So as I think again in a subsequent slide, each sort of antenatal visit, we usually see them monthly in a joint clinic. The urine is screened for infection. The rates of preterm delivery, stillbirth are all increased, and the incidence of babies that are small for gestational age is also increased. So that's why it's important, and that's why it's, you know, pregnancies in women with sickle cell disease are a high risk. I mean, that said, before I go on, I would actually say that the majority of women we look after have very good outcomes, both fetal and maternal, and that's because, you know, in general, you know, the care of women with sickle cell disease from an antenatal point of view is really quite good in the UK, provided that the care is given in an appropriate hospital. Obviously, it's a bit more challenging in sort of areas where there's a lower incidence of sickle cell disease. But that is what guidelines are for. That's also what sort of hemoglobinopathy networks are for. So advice is always available, even if it's sort of remote. But ideally, you'd want to be managing and seeing these women in a dedicated sort of hemoglobinopathy centre, which I'll go on to talk about as well. So from a preconception point of view, so this is in, you know, our ideal world scenario where you know, the patient is, you know, planning to become pregnant and wants to talk to you about it in clinic beforehand. So we would obviously want to know the hemoglobinopathy status of their partner to see if there's a risk of having a baby with sickle cell disease or a form of sickle cell disease. Obviously, you know, people can become pregnant in lots of different ways. So if you know, there's the use of donor sperm or donor eggs, you need to think about, you know, it's the person supplying those cells that actually needs the testing, not necessarily the person carrying the baby, or that will be the baby's parent, because life is complicated. So you need to not forget that sometimes, and you sometimes can get caught out. And also, if the pregnancy is identified as being at risk, the fetus is being at risk, is identified as being at risk of having a form of sickle cell disease, then it's really the decision for, you know, the mother and the couple, if applicable, to decide what they want to do with that information. So they should have adequate counselling from a trained either midwife or genetic counsellor. We don't force you know, any diagnosis before delivery if that's not what the couple want. Obviously, different people will have different views on, you know, whether they want a child with sickle cell disease, and that might be informed by past experiences in the family or personal experience of sickle cell disease. There's not for me or other members of the team to make value judgments on that. It's for us to outline the options that are available to the woman or the couple, and for them to then weigh up what they want to do. So one option is to, you know, accept that there's a risk of having a child with sickle cell disease and simply do testing when the child is born. Another option would be to have an IVF pregnancy, essentially, whereby embryos are formed and then tested for forms of sickle cell disease, and ones that are not affected are selected and then implanted. But obviously that's called pre-implantation genetic diagnosis. There are other criteria for that, i.e., you need to be under 40, I think, under 40, a non-smoker, not have a significantly raised or significantly low body mass index, and also if you have one already unaffected child, you're not eligible for pre-implantation genetic diagnosis. So there are other criteria that the NHS applies, but it is available to some couples, and the success rates can be quite high. In a specialised centre. So in London, it's most commonly on the NHS done at Guy's and St Thomas's Hospital. There's a very big centre for PIGD in the context of haemoglobinopathies. Again, not everyone will be either eligible or want that option. The second option would be to do what's called prenatal diagnosis. So that would be doing a chorionic villus sample at sort of 11 to 14 weeks. Now that is an invasive procedure. It takes, you know, cells from around the baby to then test from the amniotic fluid, and it carries a sort of 1 to 2% risk of miscarriage. And really, that should only be done if knowing the sort of sickle status of the baby would affect what you would do with the pregnancy, i.e., would you terminate a pregnancy if you knew that it was affected by sickle cell disease? Because otherwise, there's not really any sort of clinical benefit or change from exposing a woman to a procedure that has a risk of miscarriage if it's not going to change the whether the pregnancy will continue or not. But those are the options, and they should be discussed sort of as appropriate. From me as sort of the hematologist, I sort of would want to sort of appraise what we call the patient's sickle phenotype is. So that is sort of, well, regardless of what their genetic type of sickle cell disease, how does it play out in real life? So are they someone that never has sickle crises, isn't very in hospital very often, doesn't have lots of other long-term complications? Or are they someone who is, in very frequently, has a very brittle or severe type of, of sickle cell disease, that's already on disease-modifying treatment, that's under multiple specialties? So there's a very, very big spectrum of patients that you might meet. And again, as I said before, if the patient has had a previous pregnancy, we sort of want to know how they behaved in inverted commas in pregnancy. So, was it plain sailing, or did they have lots of crises? Did they get admitted to ITU? Did they have a chest syndrome and need an exchange transfusion? Was the baby born early? Did they have an emergency C-section? All of these things sort of play into sort of what we're managing expectations for any future ongoing pregnancy. The other thing to say is that you may need to involve more people or more clinicians than just the obstetrician or obstetric team and the hematology team, because, as I've said, sickle cell disease can affect lots of different organ systems, and you may then need to involve a relevant specialist. So if a lady's got kidney disease related to sickle cell disease, you may also need to involve them in the antenatal care of the patient, and that applies to any sort of organ system. I guess from a more thing specific to obstetrics, when we're thinking about mode of delivery, you can get what's called avascular necrosis of the hip. So that's where the sort of the ball of the hip joint, essentially gets blood supply chronically starved to it, and it sort of changes in shape and collapses and isn't round and doesn't fit in the sort of socket joint as easily, and causes sort of chronic pain to the patient. So some patients have to have hip replacements at quite a young age for that. And so you might be thinking of, well, how do we do a normal vaginal delivery in a lady that's got 1 or 2 hip replacements? So we're at risk of dislocating the hip. So you may need to get orthopedics to advise on suitable sort of positions that for a normal vaginal delivery, or actually deem that actually no, you can't do that at all, and it will have to be a planned cesarean. So there's lots of things potentially to think about. Iron status needs to be thought about. Obviously, iron deficiency is quite common in pregnancy and can happen to ladies with sickle cell disease, but it is the sort of opposite that I'm alluding to here. So women that are already transfused regularly might have a degree of iron overload from transfusion, and medication for that is not generally allowed in pregnancy unless it's at the very end, and only certain forms of that medication. There's a few different medications we give to remove iron. And obviously, if someone is planning a pregnancy in the future, it might be a motivating factor to sort of get their iron under control, and be more compliant with their medication to control their iron. And also, we do MRI scans of predominantly the liver to measure total body iron stores. So if they haven't had one of those recently and they're someone on regular transfusions, we would be good to get a baseline one before pregnancy. We review the patient's medication. So patients in general should be taking folic acid anyway, because patients who have hemolytic anemias are prone to folate deficiency, and we tend to recommend they take 5 milligrams once a day regardless. But some patients choose to take it, or are a bit erratic at taking it. But in pregnancy, we try and ensure there's more compliance, obviously, because of risk of neural tube defects in the fetus. Vitamin D is usually recommended as a supplement, so we should check the vitamin D level and check the patient's taking some vitamin D. Patients with sickle cell disease are sort of by definition to a degree immunosuppressed, and that's because usually in childhood, patients with sickle cell disease have crises that involve the spleen, and that is where the sort of spleen it swells with sickling, and then as that sort of process dies down, it kills off bits of the spleen, so we call that splenic sequestration and splenic infarction, and that sort of kills off functional bits of the spleen. So often by adulthood, even if the patient has retained something that looks on, you know, an ultrasound scan like a normal spleen, it won't work normally. And your spleen is important to protect you from certain bacteria, so ones that we call encapsulated bacteria. So that would be Meningococcus, Haemophilus, Neisseria meningitidis. So the patient needs to be vaccinated against those things. Some of them are covered in primary vaccinations in the UK, and the other one is Pneumovax needs a 5-yearly booster, so we check that the patient's up to date with that. But we usually recommend prophylactic penicillin, or if someone's allergic to penicillin, we use erythromycin. Now, lots of adult patients, the evidence for it really is in childhood, up to the age of sort of 5 to 7. And patients that are older than that, or adult patients, will often choose not to take regular penicillin, because it's difficult to remember to take tablets every day. Patient might feel they're already on lots of tablets. Some women get a lot of thrush from taking regular penicillin, or some patients might choose just keep an emergency stock and then only use it when they feel that they've got an infection. But if they're not someone that takes regular penicillin or erythromycin outside of pregnancy, we would normally recommend it during pregnancy, and again, usually the pregnancy itself is a sort of motivating factor for compliance on that respect. The other thing to check is, well, is there any medications we need to stop that would be contraindicated in pregnancy? So hydroxycarbamide is an oral medication that we use to treat sickle cell disease. So it raises someone's hemoglobin, it makes the sickle cells more stable and less likely to have severe sickling by increasing fetal hemoglobin levels, and it also has sort of an anti-inflammatory and anti-adhesion effect. It's a capsule-based medication, but it's teratogenic in animal models. There's no evidence really that it does cause teratogenicity in humans, although there's sort of bigger sort of retrospective studies looking at that at the moment. But there's no sort of current evidence of it. But the standard advice, if a woman on hydroxycarbamide was planning to become pregnant, is that we would stop it 3 months prior to trying to conceive. So wash out, and the same would be for a man actually on it. So we would suggest they stop that. But if a woman does become pregnant whilst taking it in an unplanned way, that's not a medical indication for a termination. So if they said, "Oh, I'm very worried that it might have harmed the baby," I would reassure them and say there's no sort of human evidence, and it wouldn't be an indication to terminate the pregnancy unless there was another reason or or a maternal choice to do so. ACE inhibitors need to be stopped. Iron chelation medication, as I said, need to be stopped. And some patients will be on new medications for sickle cell disease, including crizanlizumab or voxelotor. There's no data on those in pregnancy, so they obviously also need to be stopped in advance, or ideally in advance. If the pregnancy is unplanned, stopped as soon as we're aware that the patient's pregnant. The other thing to consider is what pain relief medication is okay to take in pregnancy. So as most of you that work in either midwifery or obstetrics would know, we just use caution with non-steroidals before 12 weeks gestation, and generally avoid them after 31 weeks because they can prevent the closure of the ductus arteriosus. Certain vaccinations, as I've already mentioned, are recommended due to the risk of encapsulated bacterial infection, but other ones are important as well, such as annual flu vaccine, hepatitis B vaccination because of the increased lifetime chance of blood exposure, and we tend to avoid live attenuated vaccines in pregnancy. In terms of sort of what we do with sickle treatment in pregnancy, if we're thinking about a sort of a planned pregnancy, we think about whether I've talked about hydroxycarbamide, and we would stop that in advance ideally. But if the patient's on regular blood transfusions, which in certain circumstances for certain complications we do put people on regular blood transfusions, do we are they already on them, and how are we going to continue them in pregnancy? If they're not, do they need to be moved to transfusions? And I've got a separate slides on that a bit later, so I won't go into that too much, but we need to at least ask the question. And if they're not on regular transfusions and we don't feel that they need them through the pregnancy at baseline, could they be transfused in an emergency if we wanted to transfuse them. So are there any patient or personal beliefs about having blood? So is the patient Jehovah's Witness, or do they have other personal beliefs about not receiving blood, and they documented clearly in advance? And do we know whether it makes a difference if the patient's in a sort of stable or life-threatening state? So that all needs to be sort of well documented ahead of time. Do the patient have antibodies against red cells? So patients with sickle cell disease are more likely to form antibodies against red blood cells if they're exposed to blood. We try and avoid that by being only transfusing if needed, and also matching blood to a higher standard than for patients who don't have sickle cell disease, but sometimes it's unavoidable that they form antibodies. And again, as I've said in the previous slide, don't forget the baby. So some antibodies, in the same way that anti-D can cause hemolytic disease in a newborn, there's lots of other antibodies to red cells that could potentially cause hemolytic disease of the fetus and newborn. So that needs to be thought about. And has the patient got any history of previous transfusion reactions? I won't talk about the TAPS2 trial now, because I'll talk about that a bit towards the end of the talk. So if we now imagine that the patient has booked for antenatal care, obviously if they haven't had preconceptual discussions or optimization, then you sort of have to do all that in a sort of more compressed time. So if if one of the specialist nurses takes a call and someone is pregnant, we'll usually sort of just overbook them in the next 1 or 2 weeks in clinic to sort of get the ball rolling with everything. And obviously they need to then book for formal antenatal care as well. If the pregnancy is thought to be at potential risk of having an affected fetus with or baby with sickle cell disease, we would aim to sort of have the results of partner screening and have gone through those with the mother or couple by 8 to 10 weeks, so that you can offer a chorionic villus sample if appropriate by sort of 11 weeks. And then usually ideally have the result back to the patient before 14 weeks. We would want to refer the patient to an obstetric medicine or obstetric hematology clinic with links to a specialist hemoglobinopathy team. So the specialist hemoglobinopathy teams in North Central London are the Whittington and North Middlesex Hospital. UCLH is what we call a HCC, so a hemoglobinopathy coordinating centre. So it does all the things of an SHT, but has also other administrative and managerial sort of responsibilities. So generally the sort of bigger centres in North Central London for pregnant women with sickle cell disease are UCLH, North Middlesex, and the Whittington Hospital. But obviously women may choose to have antenatal care for their own reasons, and also delivery at a hospital that isn't a specialist hemoglobinopathy centre, which does make things more challenging. But again, it's not impossible. But the patient obviously just needs to be informed of the potential increased risks of that. I've already talked about VT assessments, so I won't go into that again. In terms of other aspects of antenatal care, I have already mentioned aspirin, hyperemesis. We're really hot on that because obviously dehydration is a risk factor for a sickle crisis. So we try and get on top of hyperemesis quite aggressively, and probably have a lower threshold to sort of admit for IV fluids, for example, just because it is a known sort of trigger for sickle crisis. As I said before, patients usually see monthly, and those are the sort of baseline tests that we would do. The sort of protein check is obviously something that happens for checking for preeclampsia, but actually in sickle cell disease you can get proteinuria because of sickling in the kidney, which it doesn't cause pain in itself. It's sort of subclinical. So one of the early signs of renal disease in sickle cell is sort of asymptomatic protein leak from the urine. So it's good to know what the urine protein level was, at booking or at baseline, so that you can then compare it if it increases across the pregnancy. And then obviously it's a clinical decision. If it increases, you're like, well, is it related to the sickle itself, or we're worried about preeclampsia? But there's obviously other factors to take into account in that assessment. Patients with sickle cell disease get screening echocardiograms at usually every 3 to 5 years. That's because there's an increased risk of pulmonary hypertension in sickle cell disease. If the lady hasn't had one done in the last 12 months, we would normally repeat it in pregnancy itself. If they had a normal one done in the previous 12 months, we don't normally need to do it unless they develop symptoms or signs that would warrant repeating an echo. Obviously, if they've got an abnormal echocardiogram previously, you may consider seeking cardiology advice on that. And then the other thing is eye assessment. So you can get retinopathy in sickle cell disease, a bit like you can in diabetes. So the sort of hypoxia or lack of oxygen supply to the retina can stimulate abnormal blood vessels to sort of form and grow out into sort of the jelly, into the vitreous of your eye. And they're not the most sort of robust blood vessels. They can be quite friable, so they can rupture and bleed and cause a vitreous hemorrhage, which clouds vision. And pregnancy can exacerbate retinopathy in the same way that it can in diabetes. So if the patient hasn't had an ophthalmology assessment in the last year, we would want them to have one in pregnancy, but also we would normally suggest a reassessment in later pregnancy to make, if they've already got changes there, to see if anything has progressed. In terms of antenatal scans, some centres will offer an early viability scan at sort of 6 to 8 weeks. Others won't, and the patient will just have their booking scan, so 12 to 14 weeks. Obviously, you then have your 20-week anomaly scan. Growth scans are recommended 4 weekly from 24 weeks, and some centres has changed a little bit in the updated guidelines. It was previously 2 weekly from, I think, 28 weeks, but it's sort of more to the discretion of the individual centre, depending on previous results and clinical concern. But you might end up doing 2 weekly scans later on in pregnancy. Again, that's sort of an obstetric decision to make. I said that I would talk a little bit more about transfusion of women with sickle cell disease. So one thing to say is that we don't just transfuse based on the hemoglobin number. So obviously, in general, patients become more anemic in pregnancy anyway. So even women who don't have sickle cell disease can become anemic in pregnancy. It's just a normal dilution and expansion of the plasma volume that drops the hemoglobin a little bit. But that effect may be exacerbated in sickle cell disease. But we don't, just because someone's got a low hemoglobin doesn't mean we're going to jump and transfuse them because of the increased risks of transfusion in sickle cell disease. So if in a steady state patient, we would expect sort of a hematologist to be involved in that. Obviously, in a major hemorrhage, that's not the case. You don't need permission. You just manage the major hemorrhage and then involve us later if needed. If someone isn't known to your hospital, so they're just coming for sort of antenatal and intrapartum care, it's important that the transfusion laboratory knows that the patient has got sickle cell disease. They won't know unless you tell them, or unless they've sort of seen the patient before in the laboratory. So you need to tell them that the patient's got sickle cell disease and that they're pregnant, obviously, because of the CMV negative requirement for blood that's transfused in pregnant women. As standard, all donated blood isn't screened for sickle cell disease. So in theory, carriers for sickle cell disease could donate blood successfully. So blood that's given to someone who has already got sickle cell disease is specifically screened to be sickle negative. In terms of antibody matching, it's not just ABO compatible, it's matched for the rhesus groups, which is D, C, E, and also another group called KEL. There's lots of other antibodies or blood group antibodies that patients could make. So it's important they can come and go over time. So we match against any historical or known antibodies that the patient has got currently or has had in the past. So that sometimes involves asking, this is obviously more of the blood bank and hematologist job to do, sort of getting a bit more of the transfusion history, contacting hospitals where the patient has previously been transfused to sort of get that history, and then make sure that if we then have to transfuse them newly in wherever they're receiving their obstetric care, that appropriate blood is selected for them. And in general, we prefer sort of fresher units. So if we're giving a standard top up, it's less than 10 days old. If we're doing an exchange transfusion, it's a less than 7-day-old unit, but we can be flexible on that to meet other requirements if possible. As I said before, if someone's already, it's easy if the patient's already on regular transfusions, we carry them on. But if they're on medication to remove iron, we stop that, and sometimes we start it in the 3rd trimester if they've got heavy iron load, but not always. But essentially, the default would be to stop it through most of the pregnancy, and then any restarting should really be under the supervision or guidance of a hematologist with expertise in that. if someone isn't on regular transfusions outside of pregnancy, but in a previous pregnancy had a significant feto-maternal complication relating to sickle cell disease, i.e., they had a chest syndrome in their last pregnancy, or they had a very early delivery because of poor fetal growth that was attributed to placental dysfunction from sickle. Then in a subsequent pregnancy, we might think actually risk benefit favors giving sort of regular transfusions in pregnancy. And again, those regular transfusions can either be top-ups where patient comes every few weeks, is cannulated and has a couple of bags or 2 or 3 bags of blood depending on their hemoglobin level, or they can be full automated exchange transfusions, and the choice between those will partly depend on availability of exchange, vascular access for the patient, because exchange transfusions need sort of good veins in inverted commas, so fairly wide bore cannulas, or sometimes a sort of a vas cath line, which some patients won't be keen on having, understandably. Some patients will obviously have indwelling vascular access devices such as a portacath, but if you're going to do an exchange through a portacath, you need a double lumen one, so an in and an out rather than just a single lumen one. If the patient is on hydroxycarbamide, so if they're on disease modifying treatment for their sickle before they become pregnant, then that's usually an indication. I mean, there's an argument that all patients with sickle would probably benefit, or SS sickle would benefit from hydroxycarbamide, but it's usually in an adult a sign that they've got more severe disease, that it's felt that they need disease modifying treatment. So a discussion needs to be had about, well, do we swap them from hydroxycarbamide to transfusions during pregnancy or not? But that is a bit more of a nuanced sort of decision between the patient and clinician. And some patients, the pregnancy for them is already medicalized enough with enough appointments, and then to be asked to come in for regular blood transfusions, and also you have to have a cross match 2 or 3 days before, so that's another trip to hospital to have that done. Although sometimes community midwives can help with that sort of thing to reduce sort of the number of trips. It's just a lot, and if someone is trying to work or has other children, and also financial constraints, sometimes they will actually just say, look, I take your advice that you should have transfusions or consider them, but I want to see how it goes, and then if I develop a complication or my sickle really becomes unstable during the pregnancy, at that point I'm happy to entertain the idea of transfusions. So it's a very individualized decision. As I said, so for people where they are very mildly affected and we feel that they don't need regular transfusions, we in general only then do it as required. The only thing in someone that's not transfused during pregnancy, if they've got quite a low baseline hemoglobin, that can vary in patients with sickle cell disease. It can be all the way down to sort of almost like 49, 50 in some people that are very what we call hemolytic, and that's say people with SC type sickle disease, they might have a normal hemoglobin. So the normal hemoglobin for a patient really does have a wide range. But if there's someone that runs a lower hemoglobin and they're not on regular transfusions, you might consider a pre-delivery sort of top up around the time of sort of 38 to 40 weeks. And I guess that's sort of twofold. So that would be raises their hemoglobin level. So if they then have a intrapartum or postpartum hemorrhage, they have a bit more hemoglobin on board before that happens, so that they sort of bleed down to a lower level. And also it will push their sickle level in their blood down a bit, and then reduce the chance of sort of peripartum complications. But transfusion practice between, so I don't, this isn't the gospel what I'm saying. Transfusion practice, and even for example between the Whittington and UCLH in pregnancy and sickle cell disease is very heterogeneous, very variable, and even between the two centres here, for example, the practice does vary. And that brings me on to the TAPS2 study. So that is a study, so no one really knows the answer as to whether if you took all women with sickle cell disease and who didn't have sort of very sort of barn door indication for transfusion in pregnancy, so this is women that are not already on transfusion, or where the clinician doesn't feel very strongly that they definitely need it because of a previous pregnancy or disease-related complication. So this is sort of the patients where we're sort of on the fence, or otherwise trying to just have an observational approach and transfuse as required. So no one really knows whether that group of patients would do better if actually you transfuse them all, regardless. And that would include, when we say better, that means sort of fetal and maternal outcomes, both during pregnancy and and follow-up. And so there's a trial called the TAPS2 study, which takes that group of women, and obviously with informed consent, randomizes them to either standard of care, which is standard obstetric management, and if a complication occurs that justifies a transfusion, then they're transfused, versus regular automated exchange transfusions, usually every 6 weeks throughout the pregnancy. And then those women are being followed up in terms of their pregnancy morbidity, mortality, and outcomes after birth. So that is currently a feasibility study that is recruited enough patients, and it's going to move on to a wider study. So we've got that study open at the Whittington, for example. At UCLH, there is a practice of offering transfusion to almost all women in the third trimester if they're not already on exchanges. So UCLH isn't participating in the TAPS2 study, but it will be interesting to see the results of that. So just the final sort of few slides now. Just a bit of practical advice as to what to do with a patient that's admitted with a sickle crisis during pregnancy. So the first thing to think about is have you got a clear pathway locally, and that will again vary depending on how your hospital is set up and how people sort of access services. And does that vary with the gestation of the patient? So does the hospital have a policy that all women over a certain gestation go under obs and gynae with input from the relevant medical or other team, or regardless of the gestation, do they go to because they have sickle cell disease, do they go to a medical bed and then receive obstetric input? I'm not going to sort of try and dictate what I think the best option is, because that will really vary depending on your local sort of logistics and physical setup of the hospital. But regardless of where it's just important that people know with the pathway, because you don't want someone sort of calling up and people not knowing where to advise them to go, or them turning up in A&E and then no one knows, do they go under the medics or hematology, do they go to obstetrics, etc. But essentially, as long as they're somewhere appropriate and both teams are involved, then in my opinion that's okay, really, because what the most important thing is they actually get appropriate care wherever they are, rather than the sort of politics of whose name is above the bed. But that's just my personal opinion. Wherever they go, they should be triaged rapidly, and particular attention to oxygen saturations on air should be paid, i.e. because that's one of the first signs of a sickle chest syndrome. And if they are hypoxic on air and have normal saturations when they're well, then that should be a red flag that you need to sort of involve the hematologist quite quickly. There's a nice standard for strong analgesia, so if required, opiate-based analgesia within 30 minutes of presentation, and then regular reassessment of the pain. You should ask the patient if they've got a patient-specific protocol. So that is, lots of centres that look after patients with sickle cell disease will sort of write a sort of usually 1A4-sided page that of key information about the patient. So this is what their normal hemoglobin is, this is what their normal oxygen saturations are, this is what they normally have for pain relief if they come in with a crisis. Obviously, it's important to talk to the patient, because rather than just follow the protocol by the word, because every crisis is different. But it's to allow people to have sort of some advice or some guidance on how to manage the patient, at least initially. Obviously inform the hematology team early of admission, obviously inform the obstetric team if they're not coming in under obstetrics. Think about why the crisis has happened. Is it just because of the overall sort of stress on the body of pregnancy? Have they had hyperemesis if it's earlier in pregnancy? Is there an infection that we need to worry about? The other thing to say is that just because someone has sickle cell disease doesn't mean they can't have other problems that any other human could have. So for example, abdominal pain in someone with sickle cell disease isn't always sickle pain. They could just as easily have a gallbladder problem, and in fact gallstones are more common in sickle cell disease, or something like appendicitis, and that does happen in pregnancy as well. And so if the patient is saying that the pain feels atypical or that it doesn't feel like sickle crisis pain, then you really need to take that seriously, and just have an open mind anyway. Obviously, hypoxia is, sickle chest syndrome is not the only, it's the most important thing I'm worried about in someone who's hypoxic with sickle, but you need to think about other causes. So they have sort of community acquired pneumonia. Could they have a PE, for example? Could they have heart failure? Or less likely in young patients, but there is an increased incidence in sickle, so all of that's important. If they're admitted, please ensure baseline bloods are done. But particularly we're interested in what their hemoglobin's doing, and to make sure they get a valid group and screen sent with their admission bloods, because they're more likely on average than other patients to require a transfusion, particularly if they're unwell. My slides have stopped going. Next one. Oh. Yeah, so you need to make sure that I said adequate hydration is given. Don't be afraid to give sort of opiates, but towards the end of pregnancy, if prolonged periods of high strength opiates are given, there is obviously risks to the fetus. But if that pain relief is required, including a PCA, then it should and can be given. But obviously the neonatal team would then need to be informed, sort of alerted sort of prior to delivery. Please avoid pethidine, because that increases the risk of seizures, and don't forget to sort of use adjuncts that help manage the side effects of opiate based medication. So that would include antihistamines for itching, and laxatives, because opiates can obviously cause constipation. Please don't forget to reassess the VTE risk, and the default really should be to prescribe low molecular weight heparin, and explain the rationale for that to the patient, unless it's contraindicated, which usually isn't. In terms of where the patient should deliver, almost out of time, I think. In terms of where the patient should deliver, they should really give birth in an appropriate centre. So, and a centre with expertise in sickle cell disease and its management in pregnancy. But like I said, someone could present to a centre in labour that isn't a specialist centre, or choose to just have delivery at their local DGH if they don't wish to travel. But wherever they present or are delivering, then the senior people need to be involved, and if there isn't sort of on-site expertise from a haematology point of view in terms of a red cell haematologist, then they need the local haematologist then need to involve or take advice from a specialist centre. In terms of the intrapartum care, you would normally make a written delivery plan, sort of documented in some way in the notes. Obviously different places use different systems like Maternity Medway or handheld notes, etc. So a documented plan in some form is helpful, and it's usually good for the patient to have seen the obstetric anaesthetist in advance to have a discussion about modalities of pain relief in pregnancy. And obviously some patients with sickle cell disease will have a much sort of greater previous exposure and experience of sort of strong opiate based analgesia than other patients, and may have higher analgesic requirements in labour and postpartum than other patients. But that's the point of having that discussion early with the obstetric anaesthetist. In general, we would encourage delivery between 38 and 40 weeks. So that's because of the risk of late placental insufficiency. So if there's an increased risk of late fetal death in women that are allowed to go over dates. So really, if someone's approaching sort of 40 weeks, we would be talking about an induction, if they're aiming for a normal vaginal delivery. But again, that's really a discussion and decision for the obstetric team to make. But in general, we don't allow women, unless they choose to accept that risk. We don't really recommend going over dates. The mode of delivery itself is really as per the obstetric indication, but there are higher rates of cesarean section in patients with sickle cell disease, purely because of those sections are usually emergency or category 1, category 2 sections, because of increased rate of complications. And a vaginal birth after cesarean is allowed as per the standard criteria. Be aware that a prolonged labour might precipitate a vaso-occlusive crisis. So throughout labour, the woman should be kept warm, well hydrated, and given adequate analgesia. there are certain requirements made in the sort of RCOG and BCSH guideline about fetal monitoring in labour, and if obviously in a major hemorrhage you would give the best available blood, usually sort of O negative flying squad units, but you could consider it, particularly if someone's got red cell antibodies, which would increase the time to do a formal cross match. You could consider, I guess, and discuss in advance with hematologists when the patient's admitted in labour about cross matching some blood in advance, just in case. In terms of the postpartum period, the patient is not sort of home and dry once the baby's delivered. In fact, quite a lot of the complications from sickle cell disease are at the highest risk is in the postpartum period. So that includes a sickle crisis, a chest crisis, ITU admission, venous thrombosis, infection. So following delivery, patients are usually sort of put in a sort of high dependency area of the labour suite for sort of often 1 to 2 days, and observed and normally reviewed sort of post delivery by basically the obstetric and haematology team. And when it comes to the decision about stepping them down to a regular postnatal ward or discharge, obviously both teams should be involved and happy with those decisions. We keep the patient well hydrated, have close monitoring of their oxygen levels, and encourage early mobilization. Because they score a 3 on the VTE assessment, that means by default, and regardless of the mode of delivery, they get 6 weeks of postnatal thromboprophylaxis, and it's important to sort of re-educate the patient about that. If the baby is at risk of having sickle cell disease, we generally don't wait and just do the 5-day the heel prick test at day 5. We often will do either a cord or a venous sample from the baby, because the parents will want to know whether the baby's affected sooner than waiting for the result from the screening program to come through. But if that's required, that's normally documented in the birth plan by the obstetric and haematology team that have been seeing them antenatally. And practice varies, but my usual practice will be to sort of do a telephone call with the mom sort of a couple of weeks as well after delivery, just to see how they're getting on, because the postpartum period is obviously a high risk period for sickle complications. All right, that's it. So I went a few minutes over time, but I hope that's okay. And please feel free to ask me any questions if you have any.
I think we've got a hands up from Fiona.
Yeah.
Hi, good morning. Thank you. Very informative and very helpful for me as a midwife. My question is there any long-term impact of pregnancy on the progress of the sickle cell disease? So, if a mother has 1, 2, or 3, I mean, probably not going to have 3 kids, but
no, not really. No. So it doesn't cause any sort of just by pregnancy in itself doesn't cause a long-term detrimental effect to their sickle. It's a bit, for example, it would be different if for example a woman had a chest syndrome in pregnancy. That can sometimes cause a bit of sort of longer-term damage and scarring to the lungs, for example. But that would happen with any chest syndrome. That's not specific to pregnancy. So we would certainly recommend. We would certainly say that it's not damaging the patient to become pregnant. It's just that the risks are increased, and you can't really get away from that.
Video call. Do you want me to take something from my neighbour?
Oh, I think there's some noise in the background.
Oh, it's me. Okay. So just give me 1 second. Thank you for that. Thanks.
Okay, all right. I saw a question in the chat saying about, this is in the chat, about donating blood as a sickle carrier, but told after 3 donation. This is a separate issue, but I'll answer it. 3 donations that blood didn't filter properly. So that is true. So blood donors are not screened for sickle cell disease when you go and donate blood. But if you are a carrier of sickle cell disease, if your blood will pass through the filters, so when you donate blood, one of the first things that then happens to the sort of bag, the unit that's made, is it's flipped upside down and passed through a very fine filter. So some patients who are carriers of sickle cell disease, their blood will filter adequately through that filter. But in some patients, it unfortunately blocks the filter. And that is the term in the blood service is known as a quote filter blocker. And it's just, if your blood will not pass through the filter, then it cannot be used for transfusion, because the filter sort of takes out white blood cells, and to do with this, a lot to do with the safety of blood in the UK. But it's unavoidable, unfortunately, for some patients. So it's sort of, if you are a carrier of sickle cell disease, you sort of have to see if you're able to donate or not, whether you block the filter or not. But unfortunately, if you do, there's not really anything you can do about it, which I can only apologise for, really, because obviously people do want to donate. Any other questions?
Lucinda, you have your hand up.
Yeah, hi. I suppose mine isn't really a question, it's more of a bit of a plug. So my name's Lucy Buxton. I'm the lead midwife for the Maternal Medicine Network for North Central London. So for those of you that don't know about us, we're a group of midwives, obstetricians and obstetric physicians that care for women with complex medical needs across North Central London. Every hospital in the UK is linked to a maternal medicine network. I just happen to be the lead for North Central. So obviously we work really closely with the haematology teams, you know, across kind of North Central, and really just a bit of a plug to say, yeah, if you are concerned and don't really know who to go to, especially if this is a woman who presents within kind of your DGH, you will have somebody within your trust who is part of a maternal medicine service who will be able to point you in the right direction. So they're really good at kind of providing that kind of that's guiding service, if you like, to make sure that the women do get the right care from the right people. I'll pop kind of our team email address yeah, in the chat, and please don't hesitate to reach out. I mean, it can be about women in North Central London, but we do have links to almost every other network in the UK, so we can point people in the right direction if needed. Yeah, don't hesitate to get in touch with us if we can help at all.
Great, thank you for that. Was there any other last questions before we conclude today? It seems like everyone has gone quiet, so I think we'll call that a day then. But if you guys have any more questions, please do feel free to get in touch. And this presentation will be uploaded to our website. Amina, are you able to put the link to... Oh, hang on, we've got a question now in the chat. Ryan, are you able to see the chat?
Yeah, so having sickle cell disease isn't a contraindication to IVF, but you would need to fulfill the normal criteria for being eligible for IVF. In terms of fertility, men with sickle cell disease have got statistically lower sperm counts than men the men that don't have sickle, but in general that doesn't translate into them having a problem sort of, you know, conceiving. If you're on hydroxycarbamide as a man, that can suppress your sperm count a bit, so we do sperm bank them and then ask them to come off it 3 months before they try and conceive. Women in general, no, it doesn't affect their fertility. If they have got another medical problem related to their sickle cell disease, so for example, if you've got renal failure related to your sickle cell disease, that might affect your fertility, for example. But per se, having sickle doesn't affect sort of female fertility that significantly, unless there's another reason that's sort of either combining with the sickle or unrelated to the sickle that's affecting it. But yeah, IVF is allowed. Obviously IVF involves sort of hormonal exposure, so there's an increased VTE risk in a woman with sickle cell disease if they're going through IVF. But normally the provider of the IVF, whether that's on the NHS or privately, involves the haematologist, and you make a plan basically to manage that. Home birth would be maternal choice only. We would never recommend that to a lady who had sickle cell disease, unfortunately. But if you know, you can't overrule maternal choice if there's capacity, but I certainly wouldn't recommend it, unfortunately. A question about well, reduce the babies being born in the UK. So that I guess preconception counselling and partner testing for hemoglobinopathy is important to that. But there will obviously be some people that that part of that's a value judgment about whether you think that you should prevent babies being born with sickle cell disease, and some people I'm not sure that's a judgment that I should make really. But it's about sort of increasing awareness of the sort of preconceptual counselling and options, so that the first time that the woman is informed of the risk of having a baby with sickle cell disease isn't when they are sort of already pregnant. So I think it's preconception care really, and highlighting the availability of things like PIGD, because I think there's a lack of awareness of that in sort of at-risk couples. So lots of patients, when you talk about it, aren't aware of the sort of option of PIGD. Okay, all right. I think we'll call it a day there, I think.
Awesome. Thank you,
Thank you, everyone.
Attending. Thank you, Ryan. And like I say, it'll be up on the website as soon as we can put it up. Have a good day, everyone.
Thank you. Bye.
Thank you.